I'm going to talk today about telementoring. What can it do for rural health? What is telementoring? So in definition, it's distinct from telemedicine and telehealth. It uses telecommunication technology to deliver training, education, and support that builds healthcare capacity. Though related to telemedicine and telehealth, it's important to recognize that it differs. The end user or beneficiary can be a healthcare worker or a patient. Telemedicine and telehealth, in contrast, while using similar telecommunication technology in the delivery of healthcare, it delivers healthcare in real time with the provider located at a remote site. It's also a tool for technology-enabled health and care management delivery systems that extends capacity and access. The end user or the beneficiary in this instance is usually the patient. Why is mentoring important for rural healthcare workers and rural residents? Mentoring has a number of different functions. It can be used to train and instruct. It can be used as a mechanism for providing acceptance, support, and encouragement. It provides access to new opportunities for the healthcare worker or the layperson, the rural resident. It can provide information. It can provide information about health promotion. And it's also a way for coaching, role modeling, and mentoring. What are different telementoring modalities? So there are a number of different ones. Project ECHO is a telementoring modality that a lot of people have heard about. And Project ECHO is a hub and spoke model. It started at University of New Mexico in 2003, and it utilizes video conferencing technology to connect a team, usually but not exclusively, at an academic medical center. And those subject matter experts are connected with community-based healthcare workers. Sessions follow a particular format with didactics, de-identified case presentations, and interactive discussion. People are surprised to learn that podcasts are actually a telementoring modality. Podcasts are gaining more traction in medical education and as a tool for education in general. Individual consultation are another modality. That's when you have a specialist connecting with a primary care provider, usually via phone or video conference. The example we have for that is our STOP HCC, Stop Hepatocellular Carcinoma program, where we have a hepatologist connecting with primary care providers in the Rio Grande Valley and advising them, giving them information on being able to treat hepatitis C for patients within their medical home in that primary care practice. Self-paced learning via online modules and curricula is asynchronous learning, where people can access modules, usually PowerPoint presentations or slides with or without audio, and they can go through those in their own time. Webinars, we've all become familiar with doing more webinars over the last 18 months of a global pandemic. And webinars are expert presentations. They're delivered by individuals or a panel, and there's usually some sort of Q&A at the end of it. Community health clubs, people are less familiar with. So the original community health club model was started in sub-Saharan Africa around water sanitation. The community health clubs consist of lay people who learn about water sanitation and take that knowledge to their communities. Once they've taught their communities about that, they then learn about some other healthcare need and teach their community about that healthcare need. They subsequently become trusted messengers of health information in their community. Jason Rosenfeld, Dr. Jason Rosenfeld, who's on our team, has brought that model to South Texas, working with community health workers and around obesity and nutrition. What we've done for our National Rural Telementoring Training Center is to adapt that model such that the community health clubs consist of healthcare workers, and the clubs then become these virtual places where healthcare workers can meet to acquire knowledge, but also as a place of support. So what are the advantages of telementoring for rural healthcare workers wanting to access training? So it eliminates the need for travel to a major metro area. It reduces the additional time off work that is usually taken to accommodate travel for training. It reduces the cost of training for the trainee because virtual formats are usually cheaper than an in-person meeting, and the cost of travel isn't in there. It may allow the healthcare worker to access training in their own time if it's an asynchronous telementoring modality. And finally, it aids in the building of these virtual communities of practice and learning, which can be a support mechanism for rural healthcare workers who sometimes, not all the time, but sometimes are isolated. Why is telementoring needed in rural communities? This diagram just depicts the challenges for rural healthcare delivery. In focusing on the persistent challenges, this slide is from 2018, and I would say that with the COVID-19 pandemic, these problems have been augmented and are worse rather than better. But I just want to draw your attention to workforce shortage, limited access, geographical isolation, things that I have already mentioned. So telementoring offers the possibility of educational oversight on a large scale basis for rural healthcare workers. We are very particular about using the term healthcare worker in the broadest possible sense. So it includes physicians, nurse practitioners, physician assistants, nurses, medical assistants, community health workers, case managers, counselors, pretty much anyone who delivers healthcare into rural communities. Telementoring expands the mentor-mentee pool and makes educational assets more widely and more easily available. Telementoring is a mechanism for task shifting and skill acquisition, which is really important where human resources are limited. About 20% of Americans live in rural areas, yet less than 10% of physicians work in rural areas, reflecting chronic shortage. Overall, the rate of physicians per 100,000 population is a lot higher for urban areas, 53.5 versus 39.8 for rural areas. Data on health professional shortage areas as of December 2019 shows that most of those health professional shortage area designations are in entirely rural or partially rural areas. So on average, 63% of those designations are entirely rural and 6% are partially rural. Access to specialty care is one challenge. In one study, a survey of 111 rural healthcare workers from a vast number of 27 different states showed that 22% of Medicare beneficiary appointments required specialty care, but 64% of rural healthcare workers experienced real difficulty in finding those specialists. And the greatest need that it was most difficult to find specialty care in was in mental and behavioral health. Furthermore, it's really challenging for a number of different reasons to recruit, not just recruit, but retain skilled healthcare workers in rural settings. Moving on to talk about effectiveness and quality of telementoring, consistent evidence to demonstrate the relative effectiveness of different telementoring models is lacking. These models should be established on a foundation of evidence-based training methodology and should have built-in robust evaluation that looks not just at impact and outcome evaluation, but also at process evaluation, which is really important for replicability and sustainability. Moreover, measures of quality of the telementoring modality itself, not of the content it is delivering or the experience of the participants, are necessary. Why are measures of quality and success in telementoring important? Well, if we want to promote best practices for telementoring programs in order to increase their viability in rural areas, we need to know what best is. And right now we don't. And so to address the lack of standardized measures of success that can be used to promote best practice and improve sustainability of telementoring modalities in rural areas, we have established the National Rural Telementoring Training Center. Possible uses of telementoring are for clinical knowledge and task shifting, for workforce development and training, for rapid implementation of, for example, telemedicine programs, for clinic management, information and operational support, and for professional development activities. So HRSA, Health Resources and Services Administration, are financially committed to improving rural healthcare quality and access, and they showed that commitment with the last financial year Rural Health Community Awards, where they awarded over $35 million to more than 50 rural health organizations across 33 states. There was one award for a Rural Telementoring Training Center, and that's the center that I have been talking about and which I direct. Why is the National Rural Telementoring Training Center needed? Well, HRSA recognizes that rural populations have a high need of services for chronic health conditions, but as I've mentioned, access is severely limited. There have been, prior to the last 18 months, but also over the last 18 months, new and promising strategies for remotely training and supporting a rural healthcare workforce. But as I've also mentioned, there's a lack of a solid evidence base or common data elements for measuring quality. And so policymakers require strong evidence based on standardized quality measures to inform systemic transformations in rural health policy. And that's what we proposed with our grant application for the Rural Telementoring Training Center. We propose training, taking a train-the-trainer approach in any of the 6 different telementoring modalities which I described, and we are establishing standardized measures to evaluate program processes and outcomes. So what do we do? The Resources, Information, Support and Education RISE for Rural Telementoring program provides training, support and technical assistance for implementing new telementoring programs, expanding existing programs, and evaluating either new or existing programs across those 6 different telementoring modalities. Important to emphasize that it's for the center provides resources for both disease-specific clinical practice that meets rural and underserved population clinical needs, but also tools and resources for career and workforce development and training that mitigates rural healthcare workforce shortages. Important also to emphasize that our services are not disease, specialty, or discipline specific. We leave potential learning partners to tell us what their needs are, and sometimes it might be disease specific, it might be diabetes, it might be HIV, it might be asthma, but sometimes it might be workforce related. It may be tools for training community healthcare workers, for example. Our focus obviously is rural and remote America, and we use HRSA definitions for rural and remote. Who can participate? So anybody. It's a national program. We're tasked with reaching all 10 HRSA regions across the country. So wherever you are, if you have need of telementoring and need training and technical assistance for it, and your work is related to a rural area, rural or remote area, please get in touch. This busy slide is just to show that we use a very evidence-based and tailored approach to our training and technical assistance, and I hope you'll see that in your experience as you interact with us. How can telementoring programs be evaluated? So we are determining measures of quality and best practice by doing a scoping review, which we completed, plugging the gaps in that literature review with key informant interviews, and then convening a consensus expert committee to look at those data. And we are hoping to come up with our evaluation toolkit, hopefully by early next year, and that will be made freely and readily available to anyone who wants to evaluate telementoring programs. This busy slide is just to show that we are using implementation science frameworks for the project. The framework that we're using for evaluation is something called REAIM, one of many different options for implementation science evaluation frameworks. We're also using an implementation science framework to evaluate and look at our implementation. And we're using one called PRISM, which stands for Practical, Robust Implementation and Sustainability Model. PRISM works very well with REAIM, so we're using them together as frameworks and taking a very clear implementation science approach. We have a policy and dissemination component of the Rural Telementoring Training Center. We are a reliable, accessible source of expertise to support policymakers on rural telementoring programs and models. We disseminate information about telementoring programs related to health and human services and our project deliverables and findings. And we share our center resources and findings widely and in a variety of formats to maximize accessibility. I just want to talk very briefly about research and policy. So policy is defined as a course or principle of action adopted or proposed, not just by governments, but by organizations, parties, businesses, or individuals. And people often think of the level of policy influence as a government level, but it works at the organizational level and at the individual health system level and actually at the level of individuals. Translation of research into policy is important. It's why we're gathering information about these measures of quality and standards of practice so that it will assist policymakers. But why? What's the point? Building the science and research base addressing social determinants of health will inform equity-focused policy development. Strong collaboration between investigators and policymakers is needed to evaluate the impact of policy implementation. Having robust translational and implementation science helps us to understand whether those implemented policies are working. Are they working as intended? Are they specific to the populations they're supposed to impact? Are they actually improving equity or creating disparities? And importantly, are they cost effective? And finally, implementation and outcome evaluation are integral to collaboration between science and policy and can provide a foundation for performance management frameworks and responsible decision making. So in summary, we are here to deliver free nationwide training and technical assistance to organizations on telementoring for rural needs. We're here to promote telementoring best practices for use in rural areas across those 6 different modalities I mentioned. We're here to support evaluation of rural telementoring programs and services. We're here to be a reliable, accessible source of telementoring expertise to educate and inform policymakers and other stakeholders on rural telementoring. And we're here to freely and widely disseminate all the information we gather and produce about telementoring and telementoring programs. We'd love for you to connect with us. As I said, if you're even thinking or wondering whether telementoring may be of use for anything that you're doing related to rural healthcare, please get in touch with us. Visit our website, our email's up here. We're also on social media, on Twitter and LinkedIn. Thank you for your attention.